Good afternoon, everybody. This is Christy Putnam, and we've got quite a room full of people at DHS. We're grateful for those who are in person, but we hope that none of you minded us making this a primarily virtual meeting, just in regards to respect for everyone's time. It's hard to get here and back. We are going to be walking through a lot of information. We also shortened the time just a little bit to about a 90-minute period of time. We've been ending a little bit earlier with these quarterly meetings, so wanted to set appropriate expectations for time frames. But we do have a lot of information on the agenda. We're going to go over the quarterly report. We have some quality metric updates from our QHP partners. Presentations of incentives from our QHP partners, some quarterly metrics that we'll update on also. But I just really want to set the stage for, we are walking through all of the work that's being done with ARHOME, and as part of the Medicaid sustainability review process, we're looking at, ARHOME and what are the metrics and where are there areas that we still have for improvement.
Recording in progress.
And this meeting is being recorded. And the other thing I want to make sure everyone knows is that even though if you saw that you were made a panelist, please don't panic. That doesn't mean that you have to present something. It just means that we want everyone to have the ability to ask questions and chime in if they have anything to contribute to some of the discussions that we're going to have. So I want to express some welcome and appreciation to the fellow secretaries that are on here and all the other representatives from our agencies and other partners. We do appreciate you taking the time. We have a very strong belief that in ARHOME and in the programs and some of the supports and services that we offer and want to expand on offering or enhance in our offerings, we have opportunities because we have people in our programs who we really have a chance to make a big impact on their health outcomes and on their personal economic self-sufficiency outcomes. So without anything further, thanks everyone for being here today, and I will turn it over to Nell to go ahead and get us started with the materials.
Go to the next slide. I'm Nell Smith. I am a Deputy Director in the Division of Medical Services. I oversee in DMS the ARHOME program. Hopefully you're not going to have to hear me, only me. I'd love to have folks have a conversation, but I'm going to be presenting the results of the incentives in the quarterly report. The results of our quality metrics and the quarterly report. Just as a reminder to everybody, we've got advisory panel members and others joining via Zoom. Arkansas PBS is live streaming this meeting, and you can watch that now here, everybody, or watch a recording later. And today's focus is on the Health Improvement Initiative. Last meeting, we focused on the Economic Independence Initiative, but this one is health improvement. And we'll be reviewing the 2022 health quality measures, the results of the performance on health quality measures, and then the QHPs will present their health incentives. And we'll talk a little bit about the health incentives that the carriers presented as we go along in the with the results of the metrics. So you have, and if people who are in the room have a copy of the quarterly report, it will be posted on our website. And I believe it was sent out to panel members ahead of time. Well, I'm not going to go through that in detail. It's statutorily required, so that is why we do it. It also helps us keep up with changes in the program. I'm also happy to discuss anything. If you've read it and want to bring up something that I don't mention here, happy to discuss anything in that report. And also, advisory panel members, please feel free to interrupt me at any point and ask me questions. I really would prefer a discussion so that we're not having to hear my voice the whole time. So just speak up or raise your hand. Courtney will be watching. See if anybody has anything they want to mention, but just speak up and feel free to interrupt. So this is one thing that I wanted to mention about the from the quarterly report. As you probably know, we've been disenrolling ineligible Medicaid beneficiaries due to the end of the public health emergency. As a reminder, during the COVID public health emergency, the PHE as we call it, we weren't allowed to disenroll beneficiaries except under a few specific circumstances. But when the PHE ended, we began disenrolling beneficiaries in April. And you can see that since then, our ARHOME enrollment has dropped by about 109,000 people. That's about 31% of the population at its height in January when we had 350. We're also enrolling people, people who were disenrolled, perhaps because they didn't fill out their paperwork. They're coming back to us, so we're we're enrolling about 10 to 15,000 new people every month. So it's a drop, but it's also ongoing new enrollment. Next slide. So the carriers this is the 2024 premiums that we can expect in 2024 for the carriers that we expect to be in the plan. These are the 5 plans that we currently have. We have 2 Blue Cross and Blue Shield plans, and we have 3 Centene plans. And you can see on the very right-hand side the increases or decreases to the rates from 2023. And for the most part, it's good news. We have one plan that actually reduced their rates. We have and the others are minimal increases. Blue Cross did increase its rate by 8%. They were the lowest premium in 2023, and now they're going to be the highest in 2024. And just so for context, the premiums for ARHOME generally range from about $400 per month for people in their 20s to about $1,100 or $1,200 for people in their 60s. And the carriers set their rates. We don't set them for them. AID reviews them and approves them if they're appropriate. And that just like AID does for every other plan that's offered on. All right, so that's all for the quarterly report. I'm going to get into the health quality measures now. This is for 2022. The ARHOME statute calls on this panel, the advisory panel, to review and make non-binding recommendations and provide advice concerning the proposed quality performance targets presented by DHS for each participating individual qualified health insurance plan. So that's the role that we hope that you'll help us play in reviewing these measures and helping us determine targets for them. So we'll be reviewing the performance results for the 2022 plan year. That was the first year for the ARHOME program. And I first want to thank GDIT, who is sitting behind me, for they did all of these calculations for us, and we could not do it without them. They do a very, very good job with the data. And also we've got Bill Golden, who is joining me for this conversation. He's got clinical expertise, and he also has extensive experience with healthcare quality metrics. And we also have representatives in the room from all of the QHPs. We've asked them to be prepared to explain their results and other trends that we're seeing. So if you have a question, we will try to answer it, but also you guys please just speak up and join in the conversation. I'd much rather you guys talk than me. And also panel members, please again ask a question, shout it out. I'll stop, no problem. Okay. So this is just to give you a little time context. In December of 21, before the ARHOME program really started, we set the 22 performance targets for health metrics based on the 2019 and 2020 performance results. In December of 2022, we reviewed the 21 performance results and set the 2023 performance targets. And today, 2 years later, we are setting the 2022. We're reviewing the 2022 performance results for 11 of the health metrics, and then we'll review the health incentives that were offered and the 2024 planned health incentives. One thing I want to mention about we're only reviewing 11 health metrics today, not the full 23 or 24, and that is based on the fact that Centene, they provide us, all of the QHPs provide us claims data. Every quarter they submit it to us, and they realized that based on some questions from our GDIT team that we haven't been providing all of the pharmacy claims that they have. There's maybe 2/3 or a half of their members for whom we didn't have pharmacy claims for. So we're going to have to rerun those metrics. So we're presenting today the metrics that do not involve pharmacy claims, and we'll review the others at the next meeting. Oh, and one other thing about Centene's data, we have, they've last week told us that there were, they've discovered a couple, based on questions from GDIT, they have found a couple of other problems with the data. So there were some beneficiaries missing from the data. So we don't think that materially impacts the results, but it is an asterisk, and we will probably need to rerun these measures to make sure that we've got everybody in the pool. But that's just another asterisk. Okay, so we're also going to be talking about the health improvement initiative requirements. In 2022, the QHPs were required to offer one health improvement incentive for each area of focus. And you can see those 5 there listed in the bullet points. And then in 2023, we upped it and we required them to offer 2 incentives each. And additionally, the QHPs need to include all their activities to support the health improvement initiative in their annual strategic plans. You will hear their annual strategic plans at the next quarterly meeting. So one thing that the QHPs frequently say is that the differences in their performance on the metrics is due to differences in their member demographics. So this slide shows the percent of each QHP's population in the grouping that you see on the screen. So we've got income, sex, age group, rural and urban, and Black. Just pick one thing to be able to show everybody's percentages on the same slide. But you can see that in general, the populations have very similar populations, except in the area of age. Age is one of the main differences. With the Blue Cross plan, that's in the middle of the screen there, they've got 42% of their clients are 19 to 35, so they've got an older population than the rest of the group. Their other plan, the other Blue Cross plan, Health Advantage, is just the opposite. They have 62% of their population is 19 to 35. They've got a much younger population. You can also see that Health Advantage has a higher grouping of poor, lower grouping of female population, and then the Blue Cross plan has a higher population of rural and a lower population of African American. So we have 3 preventive care measures, but only one of those is ready to share today. That's the cervical cancer screenings, and we'll present the other 2 which are breast cancer screenings and chlamydia screenings in December. Okay, this slide is the incentives that the carriers offered in 2022. Blue Cross Blue Shield in blue offered, that's at the top, offered a variety of incentives, but the one that we're going to focus on is the $30 for completing a cervical cancer screening. They offered everybody who is eligible for cervical cancer screening to receive $30. And you can see that about 43% of their population took advantage of that and were awarded $30. The Health Advantage Plan had a lower uptake, and it was about 23% of the eligible populations received that incentive. And I'll also point out here that we asked middle of last week for the QHPs to provide us the denominator, so the eligible beneficiaries who did not receive the award. So they had previously given us the number of beneficiaries awarded. We asked them, it's 23,000 of how many? And Blue Cross provided that information, but Centene couldn't pull that data quickly enough for this meeting. But we did just ask for it middle of last week. So Centene offered a variety of wellness incentives, from completing a wellness visit to watching a video on their portal, and they provided they provide different number of points that translate into dollar values that beneficiaries can use to buy things on the carrier's My Health Pays portal, and they can use it for other things as well. Okay, next slide. All right, this is cervical cancer screening. The structure of these slides is going to follow this same pattern, where you have the ARHOME overall to the left, and then the QHPs all after that. The blue is 2019, gray is 2020, red is 2021, and black is 2022. And the line that goes across the slide is the 2022 target. So you can see here that none of the QHPs met the target for the year. One thing I'll also mention is that the ARHOME population includes people who are not in a QHP. We have a group of individuals who are medically frail, and those folks are in our regular fee-for-service. They're not enrolled in a QHP. So that ARHOME overall includes those folks. It also includes people who may have been in medically frail earlier. This cervical cancer screening is a cancer screening within the last 3 to 5 years. So individuals who maybe had a cervical cancer screening while they were in medically frail, but now they're in a QHP, don't get counted in these measures. So that's why you're going to see some things that kind of don't make sense when you're looking at the ARHOME overall versus the individual QHPs. This one, see, I've already said all of those things. So also, throughout, you'll see that Health Advantage only has 2 bars, and that is because they started that plan in 2021. So we don't have any data for them for 2019 or 2020.
Can I?
Yes.
So, and this is for our plan partners. So I see we're not meeting the targets for this particular one, but there also, it doesn't seem like there's a huge uptake on the incentives for getting these preventive screenings and other measures as well, where the incentives are being offered. Is there a plan for enhanced communication? I know you guys are going to talk later, but why is that? It feels like there's an awful lot of resources from our part, from the Medicaid program, coming over to QHPs to help support exactly these kinds of things with the goal of better health outcomes. But we remain at 45 in overall health outcomes on the America's Health Rankings. So, I think we would definitely like to see the needle moving a little more toward the preventive measures being used. And so I would like to understand a little bit more about, where do we feel like we're missing the mark? What can we do better to help emphasize what the metrics need to be and sort of meeting the targets? So we'll just open up that conversation.
Sure. I can start. From a Centene perspective, I would say we are doing just what you said about some enhanced communication, because agree, not seeing as much uptake as you might have thought would have occurred, right? So we've started a monthly outreach to let folks know what's available to them. Some of the incentives that we offer are available all year long, such as cervical cancer screening. Others are available, some of our power-ups, educational videos and things, they change throughout the year. So we are sending out communications, letting members know, hey, check out if you go in the portal, you can check out the article or the video today on how to get out of debt or, save more, etc. So we are trying to increase our communication to members. We communicate with them in many different ways about these incentive opportunities. Our quality folks are outreaching, constantly telling them they can earn reward if they do these things. Our call centers, our communications we mail out. So there's a lot of different touch points that we do today to try and let members know these are available, but there are just members that don't comply.
And I'm Angel Johnson from Centene as well, VP of Quality. I'd just like to add that during the time period that we're referencing, you can see corresponding trend with Blue Cross Blue Shield and the Ambetter data as we started a little bit higher and we're now climbing back out of that hole. We can't forget about the public health emergency and normalizing preventive care services. So it's going to take a little bit of an adjustment.
I think it's a great point. And just to add to that, I agree with Kim and Angel in terms of enhanced communication. We can always do better there. I also would add that we're always working with our provider partners to make them more aware of what these measures are, how we're being held accountable so that they have a better understanding of that. Well, I also feel that will generate a positive outcome with these measures as they get more comfortable with what this is and what that means to them. Then I think we'll also see an increase in what that adherence is to those measures.
Okay. And I totally agree with your point about, I know the PHE, a lot of preventive measures, a lot of trips to the doctor got stopped. We didn't have that regular cadence. We're coming back out of it. But, even before that, we were missing the mark before that. So I just, whatever we can do to be helpful in getting that more on track and supporting better communications and what can we do with our providers to.
As an aside, in our medical home program, we are incentivizing, or we do send each practice in our medical home program, which is almost all of the fee-for-service Medicaid, their cervical cancer screening rates, and they're being held accountable as well. So we're working with them as well.
Okay, thank you for that. Thank you.
So bad news is the ARHOME program overall is reducing, but the QHP rates improved in 2022 over the previous 2 years, as Angel just mentioned. And Blue Cross had the best rates, while Health Advantage, which offered the same incentive for cervical cancers screenings, had the worst rate. And that may be affected by the long look back period for the measure of 3 to 5 years, when our Health Advantage has only been around for 2. Okay. So this chart shows pretty starkly the decline in this rate. The red line is the ARHOME program overall, and then the green is black and white, and then blue is urban and rural. And this stuck out for me because the black rates are so much better than any of the other rates, and there are many other measures where that's not the case. It's the opposite. But for this one, and we saw in last year's two other preventive screening measures that the black rates were higher than everybody else. So something good is happening for the black population. Obviously not as good for the white population, but it's interesting to me. So, okay. And I've got a little, this is just things that we've already discussed, but just here for people who don't get the pleasure of hearing me drone on and on. Got a little summary, but we'll skip over those. So this is the birth outcomes. We have 3 birth outcome measures, and we're going to just review 2 of those today, the low birth weight and preterm births. The third, the very low birth weight, is in your quarterly report, so you'll have it. And I think we're going to devote our March meeting to maternal and child health, so we'll go into more depth on these metrics and what we can do to improve these rates then. But we were able to calculate these birth outcome measures with the help of ADH. Thank you very much to Renee Mallory and team. We sent over our data of Medicaid moms and babies, and they matched those to birth certificate data to determine birth weight and the length of pregnancy.
So can you ask a question?
Oh, yeah.
Explains that rate.
What
rate are you talking about? Can you?
I was just asking about the cervical cancer, but the difference between the black and white, there's a difference, and I just wanted to know, what explanation there was for that. Yeah, that one.
Yeah,
I would look to our partners to, if there's any kind of
We
analytics
attribute
behind that.
it to just the volume, the sheer volume of Black members within our plan, and their compliance being higher when you're doing calculations and percentages. If it's a smaller population and they're more compliant, then the percentage will tend to be higher. We have a larger percentage of white members within our plans, and so it's just simply based on that, on numbers.
Ratio to compliance.
Correct.
Thank you.
Because
Appreciate that.
You're welcome. We do offer the same incentives for all of our members, so there's not a discrepancy among our outreach initiatives.
I will say that may play into it as well. We have some other measures that also have very small populations for the measure, and it's the reverse.
You're correct.
Yeah.
And there are nuances among race, but in this measure, that's not our finding.
Okay.
Blue Cross, did you have anything to add to that? That's just
No,
what we saw.
I think it just follows exactly what our thinking is as well.
Okay, so this is the incentives. And there were, just for context, there were about 6,100 births in the ARHOME program in 2022. So you can take those numbers, thinking about 6,100. Blue Cross provided pregnant women with $200 if they reported their due date and completed 1 prenatal care visit. And a little over half of their eligible members received that $200 incentive, while about 72% of the eligible members in the Health Advantage plan received the incentive. The Centene plans offered case management to high-risk moms and organized community baby showers to share educational sessions, and I think they got diapers and a little gift at the end. And oddly enough, they had, for each of the 3 plans, had 13 people attend. That's not a typo.
It's no magic.
And it wasn't the same 13.
No,
No.
I've got the list of folks, not the same folks.
I will say that I believe Blue Cross also has, and I know they do have case management for high-risk maternity for moms. So this, to me, is not really an incentive, and I didn't want to make it appear that they're doing case management and Blue Cross is not, but because Blue Cross is. But they're, at any rate, so that's that.
What's involved in enhanced case management?
So we have a whole program around what we call Start Smart for Your Baby. So it's case managers that are providing those identified high-risk members with a lot of educational pieces throughout their entire pregnancy. They're in close contact with them. They talk to them on a monthly basis. They ensure they're meeting and going for all their prenatal visits, taking their prenatal vitamins. So it's a very high-touch, hands-on case management program for those pregnant moms.
It looks like Senator Irvin.
Yes. Senator Irving, question?
Yes, hi. Is there no way we need to look at this data in the same way from all the QHPs? So can we get a percentage of those eligible for and better Paul choice and the other plans versus just however many signed up or attended a baby shower? I'd like to be consistent with percentage of eligible so that we're kind of consistent with the way we're reporting from everybody, so we can kind of compare the see what works and what's not working. This is my first question. I'd like to see, of the 13 that came to a baby shower, what's that percentage of the people that would be eligible to come to that? Oh, sorry. And then
Yeah.
And then the next question, and then same with case management, would is that something that they have to sign up for, or is that just something that they provide for them directly?
Let me answer the first question first. The reason that we have that data for Blue Cross but not for Centene is we asked for that. We previously received how many people had they given incentives to. And then last week, midweek, we asked both carriers. This was something.
It was my fault. It's my fault.
No. I won't.
I asked last week.
It was a good request. I didn't ask for it earlier. It's really my fault.
Yeah.
It was a good idea, and so we asked for it late in last week. Blue Cross was able to give us the data. Centene needed more time to pull it, so we certainly will follow back up with Centene and get that information. We just didn't have it in time for this meeting.
Yeah, Senator Irvin, it's Christy Putnam. I asked last week, we were looking at the numbers of the incentives. I said, that's great that we know the numbers, but that's out of how many? What is the effectiveness of this incentive? What percentage of the population is really taking them up on it? And so it was a late ask, but I do think that it's important information for us to have going forward is for the incentives, out of how many are really uptaking them on these incentives, because I think it's important to see the effectiveness and where there needs to be more drive as far as taking advantage of the incentives, which is across the board. I mean, I think we have some opportunity there for really incentivizing further and the communications, the additional work that we can do around educating our folks on what these preventive measures help with.
But I will say, sorry.
No. I mean, I'm effective or not, and clearly if only 13 people show up for a baby shower, I'm not really sure if that's going to be effective, or if that's considered even an incentive, or is case management considered an incentive? Because case management, maybe that should just be a given. I don't know. I mean, I think, again, we're trying to move the needle. We're trying to make improvements. And so, and there has to be like a very concerted effort in order to make these improvements in healthcare quality for patients, or it's not worth, spending the money. I mean, I'm just going to be flat out honest about it. So, we have to say, these are the targets. We're going to have to exceed the targets, and that should be everybody's goals. And because if not, you're going to have, people look and go, is this going to be something that's worth spending our money on, or should we spend it a different way? And I think those are fair questions to ask. And so, particularly when it comes to this category, when Arkansas is, nearly dead last in the country. And so, I mean, I think for me, I'm just raising that as a huge level of concern, particularly around this right here. And so we've got to circle back and get the data and get it in correctly, and so that we can compare apples to everybody, and then see what's working and what's not working, and change gears, I think, quickly. So, I mean, that's what I'm interested in. And I think that's better for your population. I mean, it's obviously better for these babies and these moms. So, we need to kind of be looking at this, in my opinion, with a sense of urgency. And if we're not, then, we're going to have to make some changes. So I'm going to stop talking and just listen. If whoever would like to respond is fine.
Let me add to this. It's interesting right now, there are probably 7 or 8, maybe 9 task forces and groups working on maternal fetal issues, health department, UAMS, others. I have a nice slide deck someone sent me with these different initiatives. And probably the activities here with this program and the data we generate can cross-inform those initiatives to give them a data-driven approach as well. There's a lot of activity in the state right now. Some of them are maybe a year and a half into their work with a lot of outreach and education going on, but hopefully we can help coordinate with the data we generate.
And I'm thinking of our March meeting being on maternal and child health, and I'd love to have some of those groups come and talk about what they're doing and how we can connect. Yes.
I just wanted to add for Centene, we completely agree. We 100% agree, but for the sake of transparency, we had to disclose the numbers, and this is the audience that attended. Of course, we invited a significant number of moms, and we just had 13 show up, right? This is 2022, so we have had an opportunity to learn lessons from how we extended those invitations within the community. We have learned that it's going to require a heightened sense of urgency and more partnerships with our providers. So for the sake of what we're presenting today, we hear you, we get it, and we're working towards the same common goal.
Yeah, we're actually looking to extend those baby showers to be virtual. As Angel said, that was our first, last year was our first time to offer the baby showers. And so there's some lessons learned. A lot of folks have other children, so then they're bringing their other small ones. They're not able to actually, or they're not able to come because they can't find a sitter. So we've learned some lessons through that. As far as to the question around case management, how do they get into that? A lot of that is through those NOP process. I saw Blue Cross is actually incentivizing folks for that. We're looking at some opportunities there as well. But the NOPs are the notification of pregnancy. So the earlier we're notified that someone is pregnant, the opportunity to identify them as high risk and attempt to get them enrolled in case management, they have to agree. Obviously that, it's a two-way street there. So we reach out, we explain to them the benefits of being in case management. I will tell you, our pregnant moms are typically the most agreeable to case management over even some folks that are chronic conditions and things like that. So we do see a decent uptake for those individuals to participate in those Start Smart for Your Baby program, but that still doesn't mean all of them are going to agree or all are going to answer the phone when you call them. So obviously we attempt to get them in, and we certainly see, a correlation between the number of folks in those case management programs to the outcomes on low birth weight babies, et cetera. So our goal is always to increase those NOPs, to get those members in case management. So we're constantly chasing that target.
We engage better with the providers in the community so we can actually meet the needs.
And just to make sure I understand, is the enhanced case management offered when someone is identified as high risk, or is offered to anybody who is pregnant?
It is offered to anyone that's pregnant. Typically, we'd have to provide education and more information on the actual program and sell them on engaging in the program. Typically, if you are a pregnant mom, you're already faced with quite a bit of anxiety and challenges to get through your pregnancy. And now us calling you every week or however frequently, it's just something extra. So we have seen members that have opted out or they have elected not to participate or engage. But again, just building that relationship up front, notifying, understanding when the member is pregnant, that's going to be our key to success, and that's going to go for Blue Cross and for Centene. If we don't know if the mom is pregnant, there's no way we can engage or help, offer any care or services or education. So, just knowing that they're pregnant starts the clock. So, we're all in this together. We don't have a solution for it yet. As you can see, we still have quite a ways to go, but this is a national crisis. And so the more we learn about this, the more we'll be able to help navigate change in Arkansas.
I will say on the numbers for, just again for context, you've got 212, 203, and 178 in the Centene for case management. The 3 Centene plans had about 1,000 to 1,100 births. Now that's not, total pregnancies, but that's the context for that. Okay, next slide. So this is a low birth weight. And overall, the ARHOME program's rates are getting worse over the 4 years. Not significant change, but going the wrong way is not what we're hoping for. Qual Choice had the best rate for the first 3 years, but in 2022, QCA had the best low birth weight rate. And despite the $200 incentive, both Blue Cross and Health Advantage rates worsened in 2022. I'm not sure if they offered that before 2022, but they got worse in 2022. Next slide. So this is the same information, but by rural and urban, Black, white, and other, and you still got the ARHOME overall. The rural population has better rates than the urban population. We might expect that to be the other way around due to the maternity care deserts in the rural counties. But also Black rates are significantly worse than white rates. This slide bothers me quite a bit. It seems like we've really got to do something about that. But the good news is the rate for Black women improved in 2022. All right, so this is preterm births. Preterm births, this is babies born before 37 weeks. These rates have stagnated over the past 4 years. The ARHOME program's rate in red worsened in 2022. And again, we see the preterm rates among Black women is significantly worse than the rates for white women. This is by QHP. In 2022, Ambetter and QCA had the best rates, and they both improved in 2022. The third Centene plan, Qual Choice, had the best rates for the first 3 years, just like they did for low birth weight, but Qual Choice rates significantly worsened in 2022, up to 13.7. And also the Blue Cross rates worsened in 2022. All right, we'll skip past this because we've already talked about it. So behavioral health, we are going to look at 2 rates that examine the percentage of beneficiaries who receive a follow-up care visit with a mental health provider 30 days after being hospitalized. That's one. And those that had follow-up with a mental health care provider for mental illness after an emergency room visit. So it's hospitalization, follow-up after hospitalization, follow-up after ED visit. So Blue Cross offered their clients $100 for completing a follow-up visit 30 days after hospitalization for a mental illness. So that's they're incentivizing the measure itself. And they had 35% and 30% uptake of that incentive among their beneficiaries who had hospitalization, had a visit, an incentive among their beneficiaries who had a hospitalization for mental illness. And Centene offered points for educational videos on its portal. So the percentage of beneficiaries hospitalized for treatment of mental illness, it's mental illness or self-intentional harm diagnoses. Those are hospitalized for those conditions and who had a follow-up visit with a mental health provider within 30 days. That's the measure. Blue Cross, which offered the $100 incentive, had the best rate for this measure. And Health Advantage, which had the same incentive, actually had worse rates than the Blue Cross plans, but still better than the other, than 2 of the other Centene program plans.
So this one's interesting to me because we had sort of the opposite effect during COVID, right? During 2020 is the only year that we either met or come close to meeting the target. And so, I'm picking up on Senator Urban's point just on the sense of urgency around making sure that we're providing incentives that people are really wanting to take us up on. I understand, trust me, I understand that we can't change human behavior, but there are ways to do more outreach, to be more, to provide some additional incentives to really take a hard look at, and with a sense of urgency, not waiting for another year or 2 years. It's what can we do right now that is really going to engage people to take us up on the follow-up visits, the pregnancy prevention, all of those things. So just a sort of a statement of where we are is we really want to see some change.
I think in 2020, I think there were more people, new people,
Yes.
who stressed out, and I think that also accounted for it. And the data, when we look over it over the years, is that the follow-up issues is particularly problematic for African American men. They disappear. The other populations are pretty comparable, but African American men have very low rates of follow-up to this kind of hospitalization. What are your reasons?
Actually, I think let's go to the next slide, because so this is again the same data but different populations, different groupings of the populations, and you can see in 2020 the follow-ups increased significantly, and this is not hospitalizations for mental illness. It's which you'd expect would have gone up in in 2020.
It's the follow-up.
Right, it's the follow-up.
Yeah.
And what I'm thinking is that this is telemedicine.
Yes,
that-
I
I was gonna say,
Yeah.
it's some of the telehealth.
even though it's still available, maybe physicians aren't offering it as much as they were during 2020, and so
Yeah.
Yeah, and I
it was
think someone was
easy
more,
for people to
more
do it.
likely
So,
to hop on and do the telemedicine than trying to get them into the office.
So this is follow-up. This is follow-up after an ED visit, and you can see that instead of a big spike in 2020, it's basically all trending down the wrong way, and you'd think again that if it's telemedicine on the follow-up after a hospitalization, it's not having, telemedicine is not having the same effect after an ED visit. But so that's, next slide. This is the same thing we were looking at, just at follow-up after an ED visit, but by QHP. The Blue Cross plan had the best follow-up rates after an ED visit. This is something that I wanted to see, because I think this is interesting, that follow-up after this is follow-up after hospitalization, follow-up after an ED visit. And this is the ARHOME program overall. So, you can see that follow-up after an ED visit is going the wrong way, and hospitalization is improving. So I don't know what's causing that, but interesting data that if we had more work around the ED follow-up after ED visits, maybe that could be where hospitalization is. Okay. We'll skip this slide because we've gone over all of that.
Can I just say one thing?
Yeah.
This is Senator Irvin. Going back to what you were just talking about, I mean, yes, so two things. Number one, insurance companies, I'm not trying to anyway, but you do try to hold people accountable for people's behavior all the time with providers. And so we've seen that repeatedly. So, I mean, now, the same thing is trying to apply to this plan. So you can incentivize people's behaviors, and the casinos do it all the time. I mean, it's intermittent, reward. And so I think you have to zero in and figure out what incentives work and how people will respond to it. And the casinos have it figured out, I will tell you. But I'm just going to say, these quality measures are put in all the time with different providers, and y'all do that with providers. So the same thing is happening here. So, it's a level of just saying, is this going to work or not, and how we need to best move that needle. And I would just also say that relationships matter. Relationships with patients matter. And so whether that, in my opinion, when I look at that slide that says hospitalization has a better rate of follow-up visit versus an emergency department visit, it's because you've built a rapport with the hospital, with the nurses or whatever, the doctor that's there. And then they are spending time in relationship with that patient to get them to do the follow-up. The same thing does not occur in emergency room situation. And so that would me to say that I think y'all would have a better uptick and uptake if you look at your providers as partners in trying to communicate with their patients, and make sure that you're in partnership with them in a way to incentivize even the providers to help, achieve these things. Don't penalize, but, incentivize. And so because they're the ones that have the relationships with the patients. And so their doctors are the ones that see these patients and treat them, and they can say, hey, it would be a good idea for you to sign up for this case management program. Hey, it would be a great idea. This is an incentive you get. So, I mean, there's that level of outreach that can occur. There's incentives that you can do with providers to provide, community and partnership. When we've just passed education reform where people have to volunteer, where students need to volunteer to have volunteer credit before they graduate, which I think is a great thing, which leads me to the point of, if you need a babysitter, guess what? That's a great volunteer opportunity, because that's what I did when I was in high school, umpteen years ago, because Mount St. Mary's had a volunteer requirement before I graduated from high school. So it's just about getting into the community and engaging with people. And, and those high school kids can be the ones to volunteer to babysit for the baby shower or whatever. Or why don't you team up with a beta club at a high school? Why don't you team up with an East program at a high school? I mean, you got to think creatively and utilize the resources that are in front of you within the state of Arkansas. And there's so many opportunities to do that. And and you need to look at it like that, in my opinion. And so I wanted to say that because I want this to work, and I want it to work for everybody. And I'm very passionate about that. And then the final thing I would just say is, as we're looking through all of these different categories of people, how then can we come together to advertise or market the abilities of these incentives and of these programs? And so that might be another way of coming alongside from the state perspective. But I'm just going to throw those things out there as ideas, take them or leave them. But there's lots of opportunities here, I think, to really partner with your providers. Thanks.
Thank you. All right, so we're now going to go on to chronic conditions, and this group of measures is really about its hospital admissions for a chronic condition. So the idea here is that we don't have hospital admissions because we're controlling our chronic conditions. So there's 4 of these so all of these are hospital admissions for a chronic condition. So the first one is the incentives for chronic conditions. And there's incentives for both carriers around measuring blood pressure and getting blood pressure testing among diabetics. The incentives ranged from $15 for reporting blood pressure to $30 for a blood sugar test. And we can see that Blue Cross had very little uptake of the blood pressure reporting, 0.4% and 0.1% of eligibles, and had a little bit better luck with the blood sugar testing. Next slide. So Blue Cross had the best rates in 2022 for hospital admissions for diabetes complications, but Health Advantage, which offered the same incentives, same company, had the worst rates in 2022. And overall, ARHOME hospital admissions rates for diabetes complications has been improving over the 4 years. Next slide. And this is a same measure, but for urban and rural and race. And you can see overall we're, oh, sorry, no, this is heart failure.
What are we doing?
We're doing heart failure. Yes. So overall, we're not making much improvement in heart failure hospitalizations. The rates have been relatively flat, and admissions for heart failure is the metric in the chronic condition metrics that we'll review today that shows the least amount of improvement. The others the other chronic condition metrics have shown more improvement across the program. So this slide shows pretty stark disparities between rural and urban, with the rural rates being better than the urban rates and the white rates being significantly better than the Black rates. Also, there's more race equity in the diabetes measure that we saw previously, and rural is still better than urban, but the disparity is not as stark as this one. Okay, next. Okay, so this is hospital admission for respiratory issues. We've got hospital admissions for COPD and asthma in older adults, 40 to 65. That's what this 40 to 64. That's what this slide shows. And then we'll talk about hospitalizations for asthma in younger adults, and those are individuals 19 to 39. So in the older adults, ARHOME has the program's made improvement in both older and younger, but particularly in this measure. In the older adults, the rates for the urban population is better than for rural populations, and Black rates are better than the white rates. Next slide. This is younger adults, and I wanted to put these on the same scale, so that's why they look so small. Thankfully, we don't have a whole lot of hospital admission rates for asthma among the younger group. You still see improvement across the ARHOME program, and in younger adults, there weren't big differences between urban and rural, but white populations had better rates than the Black populations. Next slide. This is a slide that shows both the hospital admissions in older adults and younger adults for asthma and COPD. In younger adults, COPD is not included, but I wanted to, what was interesting to me was the Black and white. For the older adults, the Black population had lower rates, better rates than whites, but in the younger adults, the Black population had worse rates than the white population. It's all going in the right direction, but it's interesting to me that those are flip-flopped.
It is my understanding that I think there's a higher prevalence of smoking in the white population. So that's the driver for the COPD rate, and then the asthma as well. It's basically kind of a different issue.
And we'll skip over that. We've already talked about that. These are the overall QHP results. All QHPs met the targets, the 2022 targets that we set for them in those first 3 hospital admission ratios, which we didn't talk about, but is in your quarterly report. We also, they all met the hospital admission rates for COPD or asthma in older adults and in younger adults. None of the QHPs met the targets for cervical cancer screening, hospital admission rates for heart failure, follow-up after an ED or hospitalization for mental illness within 30 days. And we had mixed results for hospital admission rate for diabetes for short-term complications. Okay. So now we are going to hear from the QHPs to present on, we asked them to present on their experience in 2022 with the incentives that they offered and what worked and what didn't. And then they're going to present their proposed 2024 incentives. And just as a reminder, if you needed it, we have 5 QHPs offered by 2 insurance carriers. Blue Cross has 2 plans, Centene has 3 plans. Caitlin Bates will be presenting for Blue Cross. And then Kim Suggs and Angel Johnson will be presenting for Centene. I guess we're shutting. No, we'll start with Centene. Okay, that works.
All right, I will kick us off, and Angel, feel free to jump in as you see fit. So I'm Kim Suggs. I am with Centene, representing the 3 QHPs for Centene. And I, if you want to go to the next screen, I'm going to share a little bit about our rewards program. And so our vehicle for incentivizing members in a monetary way is through our program called My Health Pays. This is an established program we utilize within Centene across all of our health plans across the United States. So this is a pretty robust program that we've developed over many, many years. The way the program works, it can be tailored to each state and what you're really trying to target. Overall, certainly things like what the earnings opportunities are is also something that can be tailored. And it's typically focused into kind of those 4 areas there. So eating right, moving more, be well. So things like your preventative services and things there, and then save smart are the kind of the 4 categories that the incentives are broken up into. Folks can earn up to 5,000 points that can be converted into dollars if they so choose. So they can either use the points to purchase something through our rewards store online, or they can use the dollars to pay things, which some of these don't apply to ARHOME. So monthly premiums, they don't have those anymore. But co-pays, they certainly have some co-pays they could utilize it for. Utility bills, telecommunications, so their cell phone, and they can also pay for transportation, education, rent, childcare with those dollars. So a pretty robust program that allows, that's meaningful money they can actually use for various things. This is kind of categorized what you saw earlier. It's not broken down by QHP, it's more rolled up, but it gives you a visual of how our My Health Pays incentives are categorized around the different incentive areas within the ARHOME's flavor. So preventative care, chronic illness, economic, and then the mental illness. You can see the different things that get counted there. So we have quite a few different things that folks can earn incentives for in those categories. I don't have them all broken out here on this slide, but we'll get to that for 2024. And you can see really more of the details. But you can see overall across all of those incentives to beneficiaries, so to members, we paid out just over $1.5 million in 2022.
And how does it compare if you look at, you said you have this nationally, if you look at My Health Pays for your commercial insurance lines versus Medicaid?
Like the ARHOMEs.
Right.
Right. I would need to go back and get you more exact numbers, but I can tell you, I believe that our federal marketplace members have more uptake. Part of that is they're higher on the FPL level. I think transportation is a lot of times barriers to getting to doctor's offices, things like that. Our FFM members have some barriers around cost that our home members don't necessarily have to. So it's kind of balanced. So there's just different variables that play a role. But I will say that, our FFM members being higher up in the FPL are a little bit more savvy with technology, which some of this requires technology, not all. A lot of this is claim-based, but our educational videos and things like that, you have to actually log into the portal to utilize. So those are just all kinds of barriers that
among the different lines of business. And Blue Cross would agree. They're not.
I see them shaking their head.
Of course, we have a Medicare business, so the Medicare members behave differently than this population necessarily. So there are so many different characteristics, but we present this and we actually monitor that for effectiveness each year. Since this is fairly new, we're just kind of still getting a handle on the characteristics of this population. But so far, we think that it's moving in the right direction. We do have a lot of work to ensure that they're educated properly on the benefits that are available. But overall, I think, you'll see differences among different businesses and in different markets.
And one big thing that's really helped in the last couple of years, we were able to get email addresses on our 834 files that DHS was able to share more of those more with us. So that's helpful because we can, have those and we utilize that a lot to engage with those members. So that's been very helpful. I think we're around 70% now of that population does have an email address. So that is a good thing because it's more sticky than a phone number with this population.
And you mentioned transportation, and I think we have, I think we started in 23 requiring you guys to make sure that you're communicating to your members our net transportation.
Right. Opportunity.
Yeah, so that they hear it, not just from us, but they hear it from you guys as well.
Yeah, I think that's important. The more that we can, partner together and have those communications across the board, it's just helpful because it is hard to reach the members, and we've learned it's a constant over and over reminder that a one time doesn't usually stick. You got to continue.
And we have a younger portion of the population, and they don't necessarily prioritize the same way the older members would. So it's like wrangling your teenagers sometimes. So,
but technology, they're better.
Right.
So it's
understanding the group, just understanding the audience, basically.
All right. And to Senator Irwin's point earlier, we do have a provider incentive program where we work with our providers to also try to get, as we call gap closures, but those members to actually into the providers' offices. So we are incentivizing providers in a way. Our continuity of care program incentivizes providers for that engagement. 100% agree. The more relationship that you have with your members, the more likely you are to have them actually agree to come in and meet with you. A lot of these members come to us, if they're new, they may not have a relationship established with a primary care provider yet. So that's our, number one thing is we continually try to educate and outreach to members to go to see their primary care provider. If they don't have one, we assign them one. We provide those primary care providers with listings of who their members are and who's been assigned to them. But a lot of times they may not have ever even met with those members. So we are giving our providers phone numbers, things to help them try to contact the members as well. So we definitely do take a full approach and kind of, so to speak, attack it from both directions with member incentives, provider incentives to really try to get those members to engage.
How much is the provider incentive, or does it vary?
It varies depending on how many people they get in and what percentage of the population, things like that.
Right.
What's the range?
I don't know that.
Yeah, I would have to get our network team.
It's up to $100, but
It
it may
is.
be between 50 and 100.
Yeah. And I think there's some bonuses if they actually get a higher percentage. So
If they get 90%, they might get 125, right, or something like that.
So are we offering a higher percentage to our providers than we are to our members?
No, I would say it's a much different focus. I mean, our members can earn up to $500 each member. I would say our providers are, they're not $500 a member.
Yeah,
It's just a completely different program. And then this is also part of our My Health Pays incentives payout. This is really on around the economic challenges and power-ups. With these are really more truly are educational type videos that we are incentivizing our members to partake in. And this is just a few of the items. There's a quite an extensive list of the different things that they can do, but just some examples here is energy saving tips, money tracking, debt reduction, laundry money saving tips, how to pay down their debt, just various different things aimed at helping them better understand how to manage money and how to save money and how to get out of debt. So for 2024 incentives, it's largely a similar focus. With our My Health Pays program, still the same, 5,000 points or $500 if that can is converted over, still the same 4 categories there. And they can still use the money in the same way. This gives you a little bit more insight into the amount of dollars available for various different incentives within the program. This is basically the same that it was also in 2022, but you can see there things like a well-being survey, $50, everyone would be eligible for that to partake in that. And then there are other things within the incentives that are not all members, because not all members need to have a diabetic eye exam, etc. You can see there's some care management participation, a risk assessment. If they will take a risk assessment, that's a big bang for their buck, so to speak. They can get $250 or 2,500 points. So almost half of the dollars are available just to that risk assessment, which is important to us because that allows us to understand the member, their needs, and really what programs we can connect them with. And then you see all the quality things that it's on here because it's part of the slide, but childhood immunizations is not really applicable to this population. There's really no children in it, but certainly, like I said, it's available to all of our population. We don't necessarily offer our incentives in different ways. We outreach across the board. One thing too that we have to be very careful of, and so just want to mention this here, is that because this is a ACA program, CMS has very specific criteria around offering incentives. So we have to balance them. So if we have to offer them to all eligible participants, or there has to be a balance. So if we're doing you can see some things there. So like the colorectal screening may be targeted to men, and we have a competing one for cervical cancer screening for women. So there are rules that we have to follow around these different incentive programs. So we always are having to ensure we don't violate something with these incentive programs because they don't meet those criteria. So right.
Can you say anything about adult immunizations?
I don't think there is a incentive on adult immunizations.
But the children immunizations is offered to the children members, which doesn't, have you considered offering it to the adults who take the children for the immunizations for completion of childhood immunizations?
I don't know how we would track that because we don't cover the children, so we don't, those are claim-based. It's something we would have to, we might could get creative and come up with something.
You're not giving an incentive in the ARHOME program for the children.
Because there are,
Right, because they're not
unless
children.
they're 19 and
Right,
still
okay,
getting some
right.
type of
And because we
It's a little
don't,
bit confusing.
yeah, because it's on there. So I saw that on there. I thought I should have probably taken it
No,
off.
I just know the ACA has requirements around adult vaccinations as
Mhm.
well.
Yeah,
So I
to
just
your
didn't
point, you're right. There
know
are
if there were
some,
any instances around
Yeah.
that.
Right. Again, this just kind of gives a little bit more. It's the same, very, very similar things that we did in 2022 around the different activities. What will be different a little bit are the challenges and the power-ups, different topics. Some may be repeated topics, but for the most part, we try to create new content. We are looking this year to have more of our content very targeted toward these quality metrics. So looking to add targeted educational videos around, let's say, maternal health. Anybody can watch it, right? Moms or dads. So it's not something that we have to just limit to women, but it's important information. But so really looking to, in 2024, target our educational videos to why it's important for maternal health, or why it's important to have your cervical cancer screening, those kind of things. So very targeted educational opportunities there too. Again, as we talked about before, the points can be redeemed for dollars. Those dollars can be spent on things like utility bills, and it really comes to the member in what looks like a debit Visa card. That's how they use the dollars. So the money gets transferred to the card, then they use the card just like they would any other debit card to pay for those services. We also have community events that we have a lot of folks in the community participate with us in. These were unfortunately kind of had to go silent during the PHE and the COVID years. We finally got back into the community some in 2022, really starting to get a lot more in the community again back in 23, and able to get out into almost every area of the state. Our goal is to ensure we have things in all 75 counties throughout the year. This is some examples here. We partner with the community providers, other community supports. We do vision exams, dental exams, all kinds of things at these community events. They are community events in that we invite our members specifically to these events, but they're also open to all members in that community. So certainly not just our members attend. In addition, we also have folks now that are coming from like the workforce development area. They're sharing information with individuals in the community about, you know, openings, jobs, training, all kinds of things. Hopefully they're getting benefit from in that as well. So we've been partnering with them at all of our events, and that's been an exciting opportunity as well. We will continue these programs, our provider incentive programs in 2024 as well. Not listed, we have a few other things we're thinking about outside of these to incentivize providers to just do more. As one of the things is the NOPs. Is there a way to get providers to engage more with us and encourage or report information to us around members that may have a high risk? You don't always get the details when you get a claim. If that's all your notice is a claim, you don't necessarily know always if there's a high risk there immediately. So the more we can get that information, the faster we can engage with members. So those are other things we're also looking at doing in 2020. All right. Okay.
I jinxed us by saying we usually end this early.
Well, I think I took up more time than I should have.
We've been asking a lot of questions. I'm sorry, but we have a lot of questions.
Yeah.
So,
I think that's the difference. It's good discussion.
Technology in this room is incredibly difficult to navigate, so I just want to say thank you to Courtney, and I'll take this moment while we're having a sponsorship moment, just to thank everybody on the teams who have worked on putting all this information together. It's great data. Our team has done an incredible job of working with our QHP partners to put information together, and I think, you know, some of the questions that have been asked have been good ones to help us narrow the focus and maybe zoom in on some additional data points. So.
All right. Hey everybody, my name is Caitlin Bates, and I am representing Arkansas Blue Cross and Blue Shield today. And Matthew and Lauren are here. Feel free to chime in if y'all need to. But I'm going to give you an overview of our incentive program and results for 2022, and then how we plan to adapt that program for next year based off results. Our incentive program is called Blue Wellness Rewards. It allows us to promote healthier lifestyles for Arkansans in a number of ways. We provide education to our members, personalized recommendations based upon questions they answer or claims that we have, what quality measures they're within and need to meet, and then ongoing communications that we employ. Each of the health actions on our rewards program is related to ARHOME key quality initiatives. So there are incentives for preventive care and screenings, prenatal care, economic independence incentives. The ones that we've reviewed today, I'll review those and results of those and how we plan to tweak that for 2024. So we start with giving the message to our members in a few ways. First off, they can go to our website and see information about our rewards platform. We send out welcome materials for our members, and within that, we can talk about Blue Wellness Rewards to get the word out that way. In addition, we employ specific campaigns related to key quality measures, and we can send emails, text messages, keeping that communication open and allowing us to focus on things that matter and things that we need to improve upon. Registration is very easy for members. They can go onto an app or the web page, answer a few questions, and we gain some information about them to allow us to personalize their experience that way. Also, if they don't have phone or internet access, they can call our customer service reps and enroll over the phone. Based on responses from members and quality measures that are recommended for them, that creates a personalized action plan for the member. It looks like a simple list with just the description there. They could click on the description and see what's needed to meet each one, and they can see clearly how much they can earn for each reward. I think it's neat that they can toggle from incomplete to complete and see what else do I need to meet on my list so that I can get all my quality incentives. And we do see a lot of engagement. The members that get onto the portal, once they get that first reward, they want to keep on going. And so that's really encouraging. We just want to continue that engagement for our members. We offer 17 incentives today. We had 13 last year, so that just keeps on growing and adapting to our needs. And then finally, based on the incentives that they earn, it goes into a total bank for the member, and they can use that bank to redeem gift cards. These are digital gift cards for various retailers, local and national, and then also some physical gift cards that we will mail out in addition to some physical merchandise for members. That personalized experience that we provide really comes in our app and our webpage that the member can engage on. It gives them their action plan. You'll see there in the middle, it's got their total bank that they've earned for incentives for the year, and it tells them how much that they are eligible to earn right now. So that might change throughout the year if they become eligible for another quality measure that can grow, but this member has earned $50 of their total $100. They can click on the blue to take action, and that's their list of actions that they can complete in order to fulfill and receive all their incentives. It's Spanish right here. Obviously, it comes in English as well, but multi-language available. And then it's really easy to read and navigate. We provide an education library on our rewards platform where a member can search for any kind of key topics they want to learn about, specific to chronic conditions or weight loss, smoking, anything that is interesting to them. They can look that up and see articles and education related to it. And then finally, there are biometrics and tracking devices that a member can use. For example, a blood glucose log or blood pressure log, they can use those to be proactive and addressing their chronic conditions. Let's look closer into our incentives for 2022 and some results. So we did talk about this earlier, but I'll give you a few more details. So preventive care is core in our rewards program. We refer our members to our platform to jumpstart, to continue, or start getting healthier. We believe that the first step in doing this is to refer our members to their provider. So this is an incentive for all of our members. Everyone should get a preventive visit. And this is often one of our first marketing campaigns of the year. Get the members on the rewards program because everybody needs an annual wellness visit. Once they get on and register and see that $15 reward pop up, they can see their list of personalized actions that are also available to them. And next, we'll talk about some specialized recommendations. So we recognize the importance of prenatal care to our Arkansans. We have low birth rates, low preterm birth rates. High preterm birth rates, and a lot of low birth weight babies. And so we know how important prenatal care is to Arkansans. We wanted to encourage that for the year 2022. we incentivize $200 for a pregnant individual going onto our rewards platform, giving us the due date, and attending a prenatal visit. Now, looking at the results in our quality measures, we did see that we went the opposite way that we wanted to. Also, looking at recommendations, it is recommended to have more touches throughout the pregnancy for the expectant mom. So a minimum of 8 touches is recommended. And so for 2023, this year, we are incentivizing 4 visits. So really emphasizing that need for continuous, ongoing, more follow-up for the member. And also we added a pregnancy care manager engagement incentive, and that can be a number of ways. We have a digital telehealth platform for our maternity patients, and then we also have an internal case management program as well. So they could engage in either one of those, and that's just increasing the number of times we're talking with them. And those high-risk conditions, those get more follow-up throughout the pregnancy.
Have you determined what those incentives are going to be?
Yes, so the amount?
Yes, so what is the 4-visit incentive? So the first one visit, reporting due date, 1 visit was $200. What will the new one be?
So we give $50 per visit, so they're working their way
So
up
it's
to
the
the
same
200.
incentive.
It is, yes.
You think that's gonna work?
I will have to see the results, but I think as they're trying to meet their final reward, and so if we need to change amounts, we certainly can, and just to see how it works.
I think improving engagement with our members is also a part of that as well. So we're looking at other omni-channel ways of which to reach them, more text messages, more emails, things like that, that I think will help move that in addition to just the dollar amount. So we want to increase the amount of our members that see that and get that message to them. And I think that coupled with the reward itself will help move the needle with that measure.
It also just helped from a communication perspective and having some of the conversations with members. They might not be as aware, so they think it's like one and done. I've completed it. And so that was a part of changing it and kind of updating it for future years. Again, I think we can always evaluate and make changes as we go along, but trying to show them it's a longitudinal journey and get them on the path of going more frequently. It is 4 just because of what Centene shared of kind of a later notification sometimes of knowing that they're pregnant and not always having that opportunity, but we'll certainly look at the link.
When we get the NOP, I mean, do we communicate, I'll ask both groups, that 8 is the ideal number of visits for that prenatal care? Is that something that the members know, or is that something that we know, but maybe we just assume that others know and they don't?
It was surprising, like from the conversations that we had, that many of them did not realize that they needed to go multiple times and truly did think it was a one and done situation.
And so it sounds like you guys have done, and I'll ask both groups again, engagement of our stakeholders with the sort of tweaks that you're making around your incentive programs.
Yes.
Direct stakeholder engagement or surveys, or have you brought focus groups in? Like, how have you gotten that information? Like, how do you know that they didn't really realize that 8 visits is ideal?
So some of that's coming from care management teams or other interventions that are making with those numbers. So when you're making outbound calls to see why certain interventions aren't completed, they're sharing that feedback. It is, again, a different population and probably a significant amount more of coaching here than what we might see in the Medicare population or the commercial population. And so things that we might not have to be, we might think by saying regular care, that was clear, like keep going after your first one. But I think what's recognized is no, like we need to be much more explicit in what we say and what we do. And while 8 is certainly the recommendation, it's not always. And so that's the beauty of having Maven or other care managers for those high-risk patients who might be like, no, you have to go every week or you have to go this, and kind of customize it to that patient.
Definitely. This is a very different population. I think that, our team has probably communicated that frequently in our journey together. And I think, again, just the sense of urgency of making bigger changes faster for better results more quickly, a year by year, let's make a small tweak here and there it's just not moving the needle. And so I think we need to be much more broad in our thinking about big change that we could make for interventional and relational purposes with our people that we serve. Because we do Medicaid pays for 52%, and Elizabeth, please correct me if I'm wrong, and you may want to it's on 52% at this point of births.
It's last year's.
Yeah, it's about, it was last year, well, the 21 was 59%.
It was very high during COVID.
Right, and we remain at 48th in maternal outcomes overall. 47, 48, we hover, we go back and
We
forth.
go back and forth between those really bad to really
Right.
worse, yeah.
And so we have an opportunity with this particular population, maternal health, to really move the needle because we have most of the population of Arkansas in this category, so. Okay. Sorry, thank you.
And I think we're trying to connect the dots between, we're seeing lots of substance use disorder and multiple chronic conditions. And so our care managers are screening for that and just trying to contact more for those high-risk conditions and improving maternal outcomes in Arkansas. Okay, so mental health incentives. ARHOME, obviously a key priority for ARHOME is mental health. With 10 quality measures associated with mental health, we know that we must address mental health before we can start meeting those, chronic conditions or preventive care. So it's very important. We wanted to incentivize members for getting a follow-up after a hospitalization for a mental health condition. So going to see that mental health provider, continuing the treatment and counseling and what goes along with it. We offered $100 for our members to do that. You will notice our incentive amounts are a bit off. That was due to a technical glitch. There was a delay in administering the $100 to each member. So we went back and corrected it, but some of those members had been terminated at that time. Going back, we saw that those members were not registered at any point during 2022. So we have made sure that there is proper monitoring in place so it doesn't happen again. And we're already currently rewarding in 2023 as members complete their visits in a more timely manner. Overall, for our follow-up rates for 2022, we did see increases. We haven't met targets yet, but we hopefully are working towards that. And we hope to increase engagement with this incentive.
Can I ask, do you have a sense of why for the Blue Cross plan, something is working, but for the Health Advantage, it was lower?
We offer the same incentives and the same marketing materials to both populations. We are doing the same outreach for both populations, so I don't have insight into that.
We've been looking into some of the data, stratifying it, and so I go back to earlier when you mentioned it's a younger population in terms of the Health Advantage. It's hard because there's not enough members here to truly be able to stratify it, but that is the suspicion that likely age may be a factor here. I think one of the additions that's been made in 2023 is expanding our telehealth for mental health through Teledoc and having that opportunity for members to engage, and hoping that kind of maybe moves the needle a little bit more on Health Advantage, but also from a Blue Cross perspective.
The assumption being the younger members are not doing the follow-up as much as
That's
the
our
older members
assumption.
are.
It's hard just because there's just a much smaller, you'll see it's 97, when there's less than 500 members for a measure, it's certainly hard to stratify it. But that is certainly the assumption. It's been seen in some of the nationwide studies that younger members don't have it, or they want to do it via telehealth. And there's not as many telehealth mental health providers in the state of Arkansas as mentioned earlier.
And then follow up after substance use disorder hospitalizations as well. To mirror our other reward, we also reward $100 for those members to continue that treatment and follow up with the provider after substance use disorder diagnosis. We also do include our ER discharges on this as well, and we offer $100. And we did have the same delay in administration here, and so when we went back and corrected it, we noticed that members were terminated and they were not enrolled in 2022 for our incentive program. And so we again have been rewarding this year and assured that it's in a timely manner for this incentive. If you look at our follow-up after ER visit for substance use disorder rates, we are meeting the target for 2022, and we made big improvements for both plans for this particular quality measure for ER visits.
This is a measure we'll see in December.
Okay.
And then we want to improve the quality of life of Arkansans that are struggling to manage multiple chronic conditions at the same time and help them live longer, fuller, healthier lives. To do this, we wanted to focus on 2 chronic conditions, and the members within this have multiple chronic conditions that they are suffering to manage. And so uncontrolled hypertension, seeing the life altering complications that can result from it, we wanted to educate our members on that. If a member went onto our portal and redeemed or read the article and reported their blood pressure, we awarded $15 to those. We did not see, like Mel said earlier, a big uptake with this incentive. And we actually plan to remove the incentive for 2024 to focus on some higher priority quality initiatives such as chlamydia screening and contraception postpartum. We do plan to keep this on the portal as recommended for members, but just not have the $15 award. And we'll still have the materials out there. That's the plan for 2024 for this one. And I think it was difficult to know where to put the blood pressure. We worked through a lot of like specific member and help and guiding them through that. And so we'll keep the articles on there for education, but focusing on some other quality initiatives for next year. And then the other chronic condition incentive that we offered is related to diabetes and encouraging members to get 2 hemoglobin A1C tests during the year and that continuing management of diabetes. We offered $25 if they completed 2 hemoglobin A1C tests. But realizing that our goal was really to incentivize control of diabetes, we changed our incentive for this year, and we only offer the reward if you have a hemoglobin A1C less than 7%, so at goal, and we've increased that reward amount to $40 for this year, and just requiring the 1 test.
So they only get the reward if they're less than 7%?
Correct. And then a custom category, really you could throw this into preventive care as a whole, but women's health preventive care screenings, we offer a reward for breast cancer. Seeing the lower rate of breast cancer screenings in the state, we want to encourage breast cancer screenings and increase that number to increase survival rates from breast cancer. So we offered $50 for this incentive. You don't see a whole lot of Health Advantage members in this measure due to the long eligibility time frame. We do expect a big population jump for next year, and you'll see more members eligible for the reward from Health Advantage. Our breast cancer rates did increase for 2022, although we didn't discuss them today. We're not at target yet, but we're very close for Blue Cross, and we're going to have a rate for Health Advantage for next year because they'll be eligible. We'll have at least 50 members in that measure. And then our last women's health preventive screening is cervical cancer screening. And so seeing as we have a really high rate of cervical cancer in the state, we wanted to encourage the screening to prevent and identify cases of cervical cancer. And so we offered $50 to the members to complete a cervical cancer screening if eligible. There are a lot of members in this measure. We did see a good amount of engagement for here. We'd still like to increase it. We did see our rates overall increase for cervical cancer for both plans. We saw a Blue Cross increase from 42.4 to 43.7, and then Health Advantage increased substantially. And hopefully that's due to the incentive we offer, and we hope to have more engagement in the future. And as a digital platform, we can only do so much, and we do believe that getting members to their providers is key here, and provider engagement and education. And so I think that's key to meeting these targets.
Do you all also pay provider incentives?
We do have some provider incentives, yes.
Do you know what the dollar amounts of those are?
Yes, so they range from anywhere from $50 total to around $60.
So it does vary depending on provider group and overall relationship. So some provider groups have to meet certain targets before they get paid out, and then it's a percentage of overall reimbursement or shared savings or other opportunities. So it varies by group, and usually we'll actually put a number of measures together and require that they achieve targets in them. So there's actually, of the measures in the ARHOME program, We have about 6 of those that are key components of our provider engagement program. And they'll pick and choose which ones they want to engage with. And then depending on the number of targets that they hit throughout it will depend on the reimbursement for it.
And we've been participants in primary care homes forever and early advocates of primary care first as well. So we continue to grow providers in those 2 programs over a year-over-year basis, in addition to our collaborative health programs that we have with our hospital systems throughout the state of Arkansas. So those are our main avenues in which we have our provider incentives.
This is Senator Urban. I would like the specifics on the provider incentives that you're offering, and then the reimbursement rates, as you say. I mean, are they incentives, or if you don't meet the targets, then you get a reduction in your reimbursement? Because that's not an incentive.
So Senator Urban, it's not a reduction, it is an incentive. So the primary care first programs and our state's PCMH programs are programs we've been a part of for many years, and then our collaborative health has a shared savings component in it as well. So they are an opportunity for our providers to make over and above what they would from a fee-for-service perspective. But yes, we can definitely coordinate and provide additional specifics around that.
Yeah, I think probably for next quarterly meeting, maybe just a section specifically on provider incentives and how they compare to the beneficiary incentives. What does that look like, and what's effective and what's not with our providers, and just really looking at the whole approach. But yes, Senator Urban, I agree. I had asked for that also. So I think we want to see specific provider incentives.
And then I have one more based on the breast cancer screenings and mammograms, and I had lowered that age through legislation. So my question is, when they hit a certain age, do y'all send like a birthday card out to these women that's, that incentivizes them to go have a mammogram, and you've just turned this age and you're now qualified for a mammogram? And you know what I'm saying? Like what's your level of outreach when it comes like very specifically to these different things that you're trying? Is it direct? Is it, is it just placing it on a website, or is it direct communication via email, mail, or text message, or whatever?
For Arkansas Blue Cross, we send direct messaging to our members, not necessarily on their birthday, but we send it about 3 times a year in the form of emails, mailers, text messages. So as soon as the member meets the criteria for the measure, they're eligible. They'll see that screening on their rewards action plan when they're it's recommended. Mm-hmm.
And for Centene, we do have similar member outreach and engagement centered around well women visits and well women care. We have made direct member outreach on the birthdays before, but again, you have to pretty much gauge the audience. If it's a time when we're making other concerted, dedicated outreach to members, then that could be abrasive. So we have followed that strategy before, but we just like Blue Cross also send out mail collateral to those members as well.
Okay, thank you so much.
And then finally, the last incentive that I'll talk about is our health risk assessment. We are collecting valuable information on our members on disparities that adversely affect disadvantaged populations in Arkansas. So there are questions about racial and ethnic minority, rural status, less privileged socioeconomic status, and more. And so not only do we gain that greater awareness of our population, they also answer questions related to substance use disorder, and if they'd like assistance with that, or a risk assessment for behavioral health. And so we can have care managers outreach to those members, and then we can see what members are in need of resources for social determinants of health, such as food, transportation, and housing. And an example of this, we had a member answer that they needed help with transportation, and we had an outreach specialist outreach to the member and tell them about the transportation service through DHS, and then was able to arrange the transportation so the member could see their provider and get a prescription for their substance use disorder treatment and get that filled at the pharmacy. So it's huge, connecting these members and providing those resources. And they really do form relationships with our outreach specialists, and they're along with us through their journey. We give our members $25 for that incentive, and we do want to see greater engagement with that so that we can know more about our members. Overall, for 2024, we're continuing to look at how much engagement we get on our incentives and change our incentive plan year after year based on what matters to our population, what is motivating our members to get onto our rewards program and complete the rewards. And so based upon our level of engagement and quality metric results, we do plan on making some changes for next year. We are planning on adding 2 new incentives. The first is chlamydia screening. We have a lot of room to improve on this measure. And we think that similar to the other women's health quality measures, a lot of those members overlap. So we want to show that to our members and incentivize completing a chlamydia screening and educating them on why it's important to detect chlamydia and increase treatment and reduce the spread in Arkansas. Secondly, we want to add an incentive for contraception for postpartum women, and the reason for that is to help reduce the adverse outcomes from closely spaced pregnancies and unwanted pregnancies right after giving birth. So that 90-day critical period, we have a lot of room for improvement upon the rates for our plans. And so we hope to display that throughout their pregnancy to educate them, and they know that they can get this incentive if they start contraception after giving birth. And then for increasing incentive amounts, based on feedback from the last advisory panel meeting, we do plan on substantially increasing our reward amount for the career readiness certificate, more than tripling the max amount that a member can get for that, because we recognize what a huge accomplishment it is to earn that, and so the member can advertise their skills and get out in the workforce. It is a big accomplishment, and they have to take a test to do so. And so we want to encourage that for all of our members. And secondly, continuing education. We currently reward for that each year. If a member, it can look a number of ways, whether it's a class or a college course, earning a skill or certification. They can submit proof of that, and we're going to at least double that incentive amount for our members. And lastly, health fair attendance for rural members. We want to increase that in order to provide some extra resources for our rural members and education and get out in the community more for 2024. And then finally, planning on removing the blood pressure incentive amount, but keeping it active on the platform, just so that we can focus on increasing some amounts and adding some new rewards for next year. And overall, I think every year we'll continue to adapt for our members' needs and level of engagement we're seeing. Thank you.
Thank you. Thank you. I know we're over time. I know, I'm sorry.
No, I think it's fine.
Yeah, thank you to our planning groups and partners and just everybody who's worked on this.
I'll just have one last thing, is just to say next meeting is in December. We TBD on date and location. We'll be reviewing the remaining health metrics. We will talk about corrective action plans, which is the consequence for not meeting targets for these measures. We will hopefully have a suggestion for the group of a corrective action, a strategy for the corrective action plans. And then we'll set targets for 2024 health outcomes, and we will hear from the QHPs on their 2024 strategic plans, which include beyond the incentives, the whole strategy for it. So
yeah, just thanks to everybody who's on still. We ran a little bit late, but we used all of our time this time. Lots of questions. As you can see, we have lots of thoughts on this. We do. Our population is very different, and I do want us to move with haste and speed and urgency together to figure out And I think it's important to get some input from our members too. And I'm not sure that a lot of that has happened, because hearing from some of them and their experiences might help us all move in a different direction, from the incentives to also some of the care and access to services that we, tend to struggle with. So just thank you all, and we're gonna just improve quickly.
Get on it.
Okay, all right.
Yeah.
Great, thank you.
Thank you.
Thank you very much.